presentation, I'm going to be using pressure ulcers and wounds interchangeably, and when looking at the nutrition, I'm going to mostly be focusing on increased calorie and increased protein needs. So I did just want to get a show of hands of who's ever actually been able to see a wound before. All right, awesome. For those of you who haven't, I don't have many graphic pictures, so if you have a weak stomach, don't worry about it. My personal interest came from my long-term care rotation in North Central Healthcare in Wausau, where my preceptor actually had me watch what a wound nurse does and really emphasize the importance of nutrition for these patients. So that's what sparked my interest into looking more into this. So I want to start off with what is a pressure ulcer. It's injury to the skin and underlying tissues from pressure on the skin. The most common areas is where the skin covers the bone, such as the heel, ankle, tailbone, or hip. And then as you can see in this picture here, the weight of the body is compressing the bone and the muscle to this on the skin, in this case the mattress, causing friction on the skin, which in turn leads to tear of the skin and leading to those injuries. So I wanted to show the prevalence of pressure ulcers in the United States. According to the Agency of Healthcare Research and Quality, more than 2.5 million patients will develop a pressure ulcer annually. This costs the U.S. healthcare system around $9 to $12 billion per year. So with our intervention and help, we can help lower those numbers. So I have a quick video on the pressure ulcer staging, and I want to thank my fellow intern, Sierra, for helping me find this video.
When learning to stage pressure injuries or pressure ulcers, it's very important to be able to discern the level of tissue destruction. That's involved. So what I like to use to give a visual representation are grapefruits. So if we start with a stage 1 pressure injury, we know that the skin is still intact, but it will present with an erythema or a redness that is non-blanchable. Meaning, if I press on this, you will not see the blood evacuate that area and then reperfuse. It'll turn white and then reperfuse red again. The trick with this, however, is in patients with non-Caucasian skin, what we need to look for is subtle changes in their natural skin tone. We'll see what's called a dyschromia or a darkening of their skin tone. So don't be fooled looking for erythema in darker complected patients. And again, a stage 1 is intact skin with non-blanchable erythema or a dyschromia. Stage 2 now is actually disrupted the skin barrier function. You can see as represented here that the tissue, which is supposed to be representative of the epidermis, has now been removed. We used a zester. But basically what you can see is what would be the papillary layer of the dermis. So this is still considered a partial thickness injury because it has partially invaded the skin, but it's only removed or invaded the epidermis and that first layer of the dermis, the papillary layer. When we go on to a stage 3 and even a stage 4 or deep tissue injury, we are now talking about full thickness pressure injuries, again because of the levels of tissue involved. So in a stage 3, you can quickly see the difference from how stage 2 presented. Here we have full involvement of the epidermis, but now we have invaded both the papillary and the reticular layer of the dermis into, but not through, the subcutaneous tissue layer, as represented here by this fibrous tissue of the grapefruit. So again, this is a full thickness injury because it has fully invaded the epidermis and the dermis, but it has not gone into deeper tissue structures. When we invade deeper tissue structures, such as this representation, this is very similar to how a stage 4 pressure injury will present. And what you can see again is you have epidermal involvement, also the papillary and the reticular layer of the dermis. We have gone through and extended past the subcutaneous tissue, and now we are in deep tissue structures. This could be muscle, bone, tendon, ligament, even metal if patients have had surgery. So this is a very deep injury. This is something that needs to be readily addressed, and we need to protect these tissues to keep them viable. The other aspect that we must consider with
So I hope that gave you a good visual of what pressure ulcer staging really is, without being too graphic. So some risk factors on why someone may develop a pressure ulcer is immobility. So that could be if someone's bedridden from a spinal cord injury. Lack of sensory perception, so the inability to feel pain or discomfort. You and I would think if we're sitting in an area for too long, we can move ourselves, or if we felt a sore, we would get it checked out, but there are some patients who can't. Conditions affecting blood flow, such as diabetes or vascular disease, and then poor nutrition and hydration. So the increased nutrient needs that I'm going to focus on are increased calories of 30 to 35 calories per kilogram body weight, and 0.95 to 1.5 grams of protein per kilogram body weight. Protein is increased because it's been known to help with the healing because of the cell multiplication as well as forming connective tissue. As you can see, these needs are very increased, so supplementation is often needed for these patients. I also want to note that the Pressure Ulcer Association is coming out with new research coming the beginning of next year, so these may change. That is something to look out for. So my first study is going to look at protein loss from the wound fluid itself. I know this is an outdated study from 2010, but I really wanted to include it because I think it is such an interesting point, and I cannot find another study that looked at this. So the purpose is protein loss from wound fluid recognized as a contributing factor to the deterioration of nutritional status in the older population with severe pressure ulcers. So the recruitment was from university hospitals, community hospitals, long-term care facilities, and a nursing home, all in Japan. Inclusion included 60 years old, or you need to be 60 years old. You need to have at least one wound that produced wound fluid. And then exclusions included, or were those 60 years, or under 60 years old, and if they had a pressure ulcer and wasn't producing any wound fluid. So the data collection, the wounds were first analyzed using the design score, which stands for depth, exudate, size, infection, inflammation, granulation tissue, and necrotic tissue. And then wound fluid was collected 2.5 hours after dressing change, and this was collected using a micropipette from the transparent occlusive dressing that, like the one I have shown here. After it was collected, they used this equation to estimate the amount of protein loss, and they started by looking at the protein concentration by using the Beret method, which looks at is a chemical test that is used for detecting the presence of peptide bond. They took that number, divided all over the amount of wound fluid, divided by that collected time, which is at 2.5 hours, times 24 hours. So the results, 21 out of the 25 wounds lost less than 0.5 grams of protein per day. Then there are 4 wounds that lost more than 1.5 grams of protein per day. These are not significant results at all, but I really wanted to just focus on those 4 wounds to show you a little more in depth on those characteristics of those wounds. So when looking at those 4 wounds, the protein loss was between 1.5 to 2.1 grams of protein per day. I should have mentioned that the higher the design score, the more severe the wound is. And all these wounds scored over 20 on the design score, while the other 21 scored less than 14. The nutritional route was parenteral and oral. The protein intake and a relative protein loss is as a percentage. These aren't huge percentages, but I thought it's so interesting that there is a percentage being lost just from this wound fluid. So some strengths, they use a consistent formula. They analyzed consistently with that design score. And then it was over a year, the study was over a year, which I think is an ample amount of time to assess the wound. Some limitations, there was no mention to how many times the wound fluid was actually tested. So I don't know if this was an average per day, but or if it was just a one-time thing. Different environments, this could have affected like the wound treatment, what the participants were eating. Who measured the fluid could have been inconsistent, they never said who measured it. And then a very small sample size of 25. So the author's conclusion, the amount of protein loss could be small It may not be related directly to nutritional status, although it did increase as the wounds became more severe. After doing my EAL worksheet, I decided that the limitations outweighed the strengths and decided to give it a negative rating. I still wanted to include this article in my research presentation because I think as dietitians we really focus on protein to heal the wound, but we don't actually look at the protein that is lost from the wound. So my second study is going to look at those estimated energy requirements and protein requirements and how valid they are for these patients. So the purpose is to validate the clinical validity of the estimated energy, protein, and protein requirements in older hospitalized patients with pressure ulcers by assessing nutritional status and wound healing. So I want to point out that this was done by the same researchers as my first article, so there's going to be some similarities. The recruitment was from general hospitals, university hospitals, and 3 long-term care facilities, and once again, that was all in Japan. Patients had to be 65 or older, and who were hospitalized and had at least 1 pressure ulcer. And then the exclusion included those under 65, patients who were discharged within a week, or if they did not have a pressure ulcer. Data collection. They first looked at nutritional status at a baseline, looking at weight and BMI. They used that same design score to measure the wounds. That once again stands for depth, exudate, size, infection, inflammation, granulation tissue, and necrotic tissue. And then after 3 weeks, nutrition status, calorie and protein intake, and wound status were measured. Calorie and protein intake were measured using nursing notes of the proportion of the meals consumed, plus any supplements the patients may have taken. And then the nutrition was calculated using the dietary menu from each facility. So what were the results of the study? So, sorry if this is a little blurry, but the y-axis shows a design score, and like I mentioned, the higher the number, the more severe the wound. The x-axis shows a baseline, the time from baseline to week 3. The dashed line indicates those who do not meet the recommendation of 30 calories per kilogram, where the solid line are those who met or exceeded that recommendation. As you can see, the solid line decreased in design score more than the dashed line in those 3 weeks, even showing a significant p-value. This graph is similar to the first one, but it's looking at protein. So the dashed line indicates those who do not meet the 0.95 grams per kilogram recommendation, while the solid line represents those that met or exceeded that recommendation. As you can see, the solid line did decrease a little more than the dashed line, but not showing a significant score as the calories. So some strengths of this study: they had the consistent data collection. They had consistent wound treatment. They actually trained all the wound nurses at each facility to treat the wounds the same way, so there wasn't any difference in that. They even did protein adjustments for patients with renal insufficiencies to increase the number of participants. But then looking at the limitations, the length of the study, only 3 weeks, I don't think that's an ample amount of time to actually assess a wound. There was no control on what patients ate, and then there was no record of supplementation, even though they did say they were looking at it. So the author's conclusion: estimated energy requirement and average protein requirements were clinically validated for prevention of nutritional decline and healing of pressure ulcers. After doing my EAL worksheet, I decided to give this a positive rating and wanted to include it as a resource if someone ever questions why these nutrient needs are so increased for these patients. So my last study is looking at nutritional formula enriched with arginine, zinc, and antioxidants for healing of pressure ulcers. So the purpose was to evaluate whether supplementation with arginine, zinc, antioxidants within a high protein, high calorie supplementation improves pressure ulcer healing. So the recruitment was from a long-term care and home care services. Inclusions included patients must have a stage 2, 3, or 4, so the more severe wounds. They must be malnourished, and they classified malnourished as a BMI under 21, low serum albumin, unintentional weight loss, and decreased intakes. And then they must be able to drink the supplement, and they also had to provide written consent from either themselves or a guardian. And then there's a lot of exclusion factors, so I included a few of uncontrolled diabetes, acute organ failure, sepsis, cellulitis, and artificial nutrition. So this is just a quick breakdown of the study. So they assessed 279 participants. 79 were excluded because they did not meet the criteria. They then took those 200 and assigned them to an experimental formula and a control formula. And then their wounds were assessed at 4 weeks and 8 weeks. So I just wanted to include and show you what all was in each of the formulas. So I wanted to point out that protein and calorie needs are very similar in each of the formulas, but in the experimental group, arginine, zinc, copper, manganese, selenium, vitamin E, and vitamin C were substantially increased. So I'll give you a second just to compare those two so you know what was in them. So, data collection, they initially assessed the wound for the stage. Like I said, it needed to be a 2, 3, or 4. And then wound nurses were trained to actually assess the wound area, so then the results were kind of consistent. So the results, the primary endpoint looked at the mean reduction in pressure ulcer area at 8 weeks. The experimental formula had a mean reduction of 63%, while the control formula only had a 43% reduction. So some secondary endpoints. The first one looked at a pressure ulcer that had 40% or greater reduction at 8 weeks. In the experimental group, 73% of those pressure ulcers had the reduction, while only about 52 in the control group had that reduction. The last secondary endpoint looked at the results looked at the percent of wounds that completely healed, and in the experimental group, that was 15% of the wounds, and in the control group, that was only 8%. So some strengths of this study was the length of the study. I think 8 weeks is an ample amount of time to actually assess a wound. Consistent data collection by training all those nurses. Similar protein and calorie intakes. And then they even, I didn't mention it, but they recorded the energy and protein intakes in the diet for each patient. Limitations, there was really specific inclusions, which I think in turn affected the number of participants. And then there was no record of arginine, zinc, or antioxidants in the diet, which I think could have skewed some results. So the author's conclusion, among malnourished patients with pressure ulcers, 8 weeks of supplementation with an oral nutrition formula enriched with arginine, zinc, and antioxidants improved pressure ulcer healing. After doing my EAL worksheet, I decided to give it a positive rating because I think the strengths definitely outweighed the limitations. So in my professional opinion of the whole topic, I think it's really important to be aware of these increased needs for each patient and remember that each patient is individualized and so is each wound. With nutrition-focused physical exams becoming more popular, I think it's going to be awesome that we can actually watch the wound transition and really help with that healing even more. And then since these needs are so increased, that finding supplementation with that arginine, zinc, and antioxidants can really be beneficial for those patients. Any questions?